RetinaRounds, episode number 189, Irregular Intraocular Foreign Body. Today, Dr. Rahimy and I review a fascinating and challenging case submitted by Dr. Pravin Patil, a vitreoretinal surgeon at the Shri Venkatesh Eye Institute in Mumbai, India. A patient wearing a silver anklet had its snag on her clothing. When she pulled on it, the anklet broke and a fragment struck her eye, resulting in an irregular intraocular foreign body and decreased vision. The video highlights a surgical approach to removing an irregularly shaped intraocular foreign body with a concurrent pars plana lensectomy, illustrating key intraoperative strategies and pearls that are relevant for surgeons managing similar trauma cases. Thank you, Dr. Patil, for sharing this case. All right, so here's the patient prior to the vitrectomy. You can see here that it looks like there's an entry wound in that right at the limbus there. It looks like it's been closed with nylon suture. And you can see the surgeons here are putting in their trocars. So, one question in a patient who has an IOFB is, are you opening up the conjunctiva and exploring for potentially a ruptured globe, or do you go straight for the vitrectomy? What are your thoughts on that?
Whenever dealing with trauma, especially in IOFB, I like to tell our fellows, just you'll never be faulted for going the extra mile here. So doing a paritomy, a cut down, checking everywhere, no one's ever going to fault you for that. Generally speaking, it's like what I like to do just to make sure you don't have any like posterior extension of a trauma or potentially an entry exit wound that you may be dealing with here. In this particular case, it looks like the globe's fairly well formed. I imagine they got preoperative imaging, either whether that's CT scan or ultrasound imaging, something that made them pretty confident that the globe is formed, the pressure's holding, and it looks here that this wound at least looks um, parallel to the limbus here, involving just that corneal limbus. So you don't see any obvious scleral extension. So I don't fault them per se for going straight to the vitrectomy here. How about yourself?
Yeah, my preference is just to open. I always open for these eyes because if there's enough trauma to have an IOFB, there's probably enough trauma to cause a rupture somewhere. I think how old the trauma is kind of may play some role here. So if this was maybe a remote trauma, even if there is a rupture, if there was a rupture at the time of the trauma, probably that wound is already fibrosed and is closed. But
Mhm.
I prefer to just open, explore. If there's any sign of rupture, or if maybe it looks like a self-sealing a rupture site, I'll just reinforce that with some more sutures. And then
Are
the other
you taking
reason,
advantage of that to put a buckle on? What's your
yeah,
feelings on these trauma cases?
you're reading my mind. That's exactly what I was about to say. Is the other advantage of opening is that in these trauma eyes, I'm going to put a band on for the most part. Um, it's relatively easy at that point. It's just another 5, 10 more minutes to just sew a band on. Even if the patient doesn't have an RD, I think that there is an argument to be made to prophylactically put a buckle on because these patients are at high risk for developing a retinal detachment. If they already have a retinal detachment, they're at high risk for PVR, and so the band is going to be helpful in that regard. And it's much easier, I think, in this first surgery to go ahead and put a band on than to have to reopen the conjunctiva and put it on at a later date if that becomes necessary. So I prefer just doing all at the same time. So you can see here they're actually the surgeons here have done a pars plana lensectomy, 23 gauge instrumentation, remove the lens. Looks like there's some residual cortical material, possibly some dehemoglobinized vitreous hemorrhage here. And you can see some of this there. It looks like there's the IOFB there. You see that sort
Oh
of
wow, yeah,
cylindrical metallic
coming into
foreign
view.
body that's there right where that entry site is. And so with the IOFB sort of in that anterior chamber, it's a good opportunity to try to maybe put some viscoelastic in the anterior chamber so that it sticks there. It's a little bit tacky, and so it can help to prevent that IOFB from falling to the posterior segment. But the tricky thing here with these irregular IOFBs is how do you grasp it? You may not have the right type of forceps. Even if you have bigger forceps to hold this, it can be very slippery. Um, Surgeons here are doing a little epithelial debridement with the keratome. It looks like they're going to try to explant this through a clear corneal wound.
Hmm.
So in this scenario, Hassan, what kind of instrumentation what are you asking for to help you take this IOFB out?
Yeah, the size of this IOFB looks fairly large. I don't think your traditional forceps are going to be sufficient to grasp this. So you can always try by starting with either 23 gauge, either an ILM forcep or a max grip forcep. But assuming you can't, some people may lean on a soft tip to try to aspirate it up into the pupillary plane and then grasp it with a larger grade forcep like they're trying to do here, although it's slipped to the back. You had suggested previously, you could try lassoing this with a flex loop. And you can try to create a snare yourself too to get the IOFB out of the eye. These are all reasonable options. One question I was going to ask you is now or even previously where it was just kind of hovering in the front, you haven't really done a thorough bit in the back and you don't know the gauge of this IOFB. I think the temptation is just want to, it's close through and get it out of the eye. I don't know if that's the best next step. What do you think?
No, you're absolutely right. I think that this is you can see here that this IOFB is entangled in vitreous, and so just pulling that IOFB out through the anterior chamber, you're most likely going to drag vitreous. You have a very high risk of developing a retinal break. So I think it's a prudent approach here to just use the cutter, lyse any of these vitreous adhesions to the IOFB, mobilize it. Now, you don't necessarily have to, if the patient doesn't have a PVD, you don't have to create the PVD. You don't want this thing um, ricocheting around in the posterior segment, potentially causing an iatrogenic trauma to the retina just from the movement of the IOFB. But I think removing any vitreous adhesions to the IOFB is going to be an important step before trying to explant it. Again, just to try to decrease the risk of a iatrogenic break.
I agree. Also, just, getting a sense for the total size and the shape of this, starting to plan strategically how I want to explant this out of the eye in terms of how I'm holding my hands externally. Seeing the shape of this, I'm somewhat reminded of, I can count on one hand the number of times I've had to do this in my career, but we've had situations with dislocated capsular tension rings, the CTR rings, cataract surgery, and we got to get those out of the eye. They're not necessarily amenable to be cut because they're usually made out of PMMA. So you have to actually rotate it, literally rotate it out of the eye. It's not a matter of just pulling it straight out of the eye. And due to the curvature of this IOP, I think it would require some kind of similar strategy. But I like what they're doing here. They're freeing up any entangled vitreous around it. That's the key. I agree with you. You don't necessarily have to induce your PVD at this stage, but free the IOFB of any attached gel. Try to lift it into the AC. I'm curious to see how they're going to get this up, get that out, and then you can deal with the rest.
I
Are
think putting
you,
something in there to protect the macula is an
yeah,
important step here too. What are you going to put in here? Are you going to put PFL, viscoelastic? What's your choice?
yeah, I was just about to ask you, or is this a case you're going to throw down PFO? And I think you had mentioned this to me earlier. Colin McCannell had done a nice study on this, demonstrating that, dispersive viscoelastic works just as well as, breaking open PFO here. I think, in fact, it may actually help slow down your IOFB just as well, if not better, than having PFO in the eye. So, yeah, the idea here is you want something there to protect your nerve and macula in the event that you drop something back and it falls back. You have something kind of buffering, and at least until you get your hyaloid up, that residual vitreous back there may be doing some of that job for you. But if I had to pick anything, I'm going to put in some viscoelastic back there. What about you?
Yeah, I think a dispersive viscoelastic over the posterior pole would be my go-to here. And actually, I put some dispersive viscoelastic in the anterior chamber too if I was planning on explanting this through that clear corneal wound anteriorly. Actually, my preference would be just to take it out through an enlarged sclerotomy. But if you are going to take it out through the corneal wound, I think it's a good idea to put some viscoelastic, and that the tackiness of that dispersive viscoelastic is going to help that IOFB adhere, so it's less likely to fall back to the posterior segment. You can
It's
see actually
surprising that the forcep had a big enough platform to grasp this.
yeah, that I was surprised by that too. And sometimes actually you can kind of open up the forcep a little bit, so it has a little bit of a wider grasp, and it doesn't interfere with the integrity of the grasping mechanism. But you can see here they're doing a little bit of a handshake maneuver going through that clear corneal wound.
I think this
And
is one of the areas where you mentioned having the viscoelastic and the AC is potentially helpful. Like, may help prevent some of that iris tissue prolapse. If you really deep in and fill up the AC. It gives you a little bit of wiggle room while you're trying to get your other instrument in there to grab the IOFB. But they got it out of the eye, very nicely done. It's a very oddly shaped IOFB. It can be very tricky pulling these kind of things out.
Yeah, kind of incredible. What a large, irregularly shaped IOFB. And then closing that clear corneal wound, of course, would be the next step to make sure that the eye is pressurized, repositing the iris tissue before doing that, of course. And
Definitely.
now,
Yeah, you
now the
don't need
surgeons
that.
are going to
Technically, don't
tackle
need
the
that
posterior
wound
segment.
anymore at this point. So close up the corneal wound, get the iris tissue back in. That'll help prevent any further prolapse from it. Because once it comes out once, it's going to want to keep coming out for the duration of this case, assuming you're going to be doing things like scleral depression, etc.
So it
I
looks
think you
like
make
there may be some chronicity to this IOFB because there's sort of mixed hemorrhage here. Some of it's dehemoglobinized, some of it's a little bit fresh appearing.
hmm
So, with any IOFB, the concern is going to be infection risk, of course. So what are you doing here? Are you putting antibiotics in? Are you using betadine? What's your approach?
I think either approach is reasonable. We've had good success kind of following the footsteps of some of our Japanese colleagues in these high risk cases, whether it's somebody with endophthalmitis or if it's high risk or endophthalmitis, like an IOP case, putting some dilute betadine into the infusion bottle, usually 2.5 cc's of your 5% solution injection to the infusion bottle. Gives really good, antimicrobial prophylaxis during the course of surgery. As you know, betadine kills all things, not just bacteria. So it's nice to include. Obviously, consent the patient to let them know that this is technically off label at this time, but I find that most would prefer to have that rather than doing nothing. And if you didn't do that, I think injecting antibiotics into the eye is entirely reasonable too. But they did Benko, Septaz, potentially something that could be if you're worried about fungal infection. These would all be, I think, case by case basis depending on what type of wound this is, what type of IOFB are you dealing with? Was it like a dirty, contaminated wound or not? Was this a projectile injury where you're potentially dealing with heat, as we've talked about? Almost sometimes sterilizes the IOFBs, and then you don't really see much of an inflammatory and infectious response. So every case is different.
There's an interesting series of cases out of the armed services looking at IOFB injuries and delayed IOFB removal. And actually, the endophthalmitis rate was fairly low, presumably because these are high velocity projectiles that are sterilized before entry into the eye. But I think regardless, good idea, good practice just to inject some antibiotics at minimum, even if there aren't any clinical signs of endophthalmitis. These are high risk eyes, and so you want to just be as proactive as possible. Now you can see here that this patient actually doesn't have a PVD,
Yeah.
and must be a younger patient. So they've put in some triamcinolone to help stain the hyaloid here, and they're trying to induce the PVD. Any tips here? What do you tell your fellows when they're trying to induce a PVD in an eye like this?
Again, younger the patient, these hyaloids can be pretty stuck down. So being patient, go slow. Uh, you're seeing this kind of like J-shaped maneuver where you're engaging the gel through your cutter's mouth and kind of curving around, moving in the direction of the cutter's opening. And you just kind of just keep slowly working at it, and you should hopefully should pop off here eventually. Now, if you're really dealing with something stuck down, you can sometimes use a MVR blade, bend the tip, try to get in there, create like a hyalotomy or something to just lift it up and create an access point for yourself. What other things are you considering?
Yeah, I think creating a little hyaloidotomy is a good idea. It allows for some BSS to get into the subhyaloid space and sort of hydrodissect up the vitreous. I think here also spending a little bit more time aspirating at the edge, really gathering up the gel that's there and then lifting. You can see here they've were able to actually elevate the hyaloid there in that
Nice, good.
maneuver. Very nice job there. But I think just some people even kind of they swirl the cutter around the edge of the optic nerve to try to gather up as much vitreous as possible before pulling. And I think that's really the key thing is to get a good purchase, good high vacuum aspiration of the vitreous around the edge of the optic nerve before trying to elevate the hyaloid.
What is your time frame for thinking about a secondary lens in this case?
Yeah, that's a great question. I mean, I really don't think that there's any rush here. We don't know what's going to happen with this patient. Are they going to develop a retinal detachment? Are they going to develop maybe, depending on the nature of the foreign body, is there some indolent endophthalmitis that's going to affect this patient's eye? So I'd give it, a number of weeks to months to assess the clinical stability of the eye before considering putting in any new implant into the eye. Especially with an IOFB, I think you want to really kind of take that slowly. And in a patient who is aphakic, it also gives you an opportunity to see what their vision potential is. So you can start by maybe trying with a contact lens, see what their vision potential is. Maybe they'll be happy with the vision just with a contact lens, and you don't need to do anything more, no further surgery. And even if you do elect to put in a secondary lens down the road, that aphakic contact lens is going to give you a sense of what the vision potential is. What the patient gives a patient a sense of what their vision potential would be with the secondary lens. So I think there's value in just sort of taking it slow and really assessing the vision potential before putting in a new implant. What about you?
Yeah, I totally agree. I think for me, minimum waiting 3 months. I may even just have them go get their refraction done for a contact lens fitting for all the reasons you said, see what the vision potential is in this eye. Whether or not they, get acute infection or endophthalmitis doesn't change the fact that they can still have other types of injury to their retina and macula. So I would really scrutinize your postoperative imaging you have it, able to get OCTs of your macula, looking for signs of attenuated ellipsoid, potentially, depending on this is an IOFB here, looks metallic, depending on the composition of it, whether it's iron or copper, depending on the percentage that it is, if it has copper component, there can be like retinal toxicity here. So it's one of those things that case by case basis could warrant additional testing, whether it be an ERG down the line as well too.
Yeah, all great points. So it looks like they did a peripheral shave here, and fortunately, no peripheral retinal breaks. Sort of miraculous given the size and irregular shape of the IOFB. Just cleaning up things a little bit here. Looks like there's still some leakage to that entry site, so you probably want to put in some additional sutures there to close that wound. But all in all, really challenging case with a very irregular IOFB and really nicely managed by Dr. Patel. So thank you very much for sharing that case with us.
Very cool case. Very nicely done. Handled very nicely. Congratulations.
If you enjoyed this video, please visit us at RetinaRounds.com. There you can sign up for our email list. You'll get a notification every time a new video is posted. And if you have an interesting video or a tip or trick that you'd like to share, please follow the links on our website and you can upload your video there. Thanks so much for watching.